I'm pleased to be joined by my co-moderator, Dr. Adams. You've had a nice, peaceful morning, haven't you, Dr. Adams?
So far, so
Nothing going on? Excellent meeting. It was standing room only this morning, so congratulations. Dr. Mike Mack.
Randy,
Dr. Mack, good
pleasure
to see you.
as always.
Good to see you. Francisco Maizano, who they have on the program, has moved back to Milan, but I know for a fact that you live in Zurich. Is that correct?
Correct.
Good. Vino Thrani from Emory in Atlanta. And then our friend here, Dr. Gualdi from
UVA.
University of Virginia. Is that correct?
That's right.
Okay. And then Rob Smith from the Baylor Healthcare System. So, David, you want to start off by kicking this thing off?
Well, I'm happy to. What we were trying to do is have sort of an open mic discussion with several experts in the field in transcatheter valve therapy, particularly as it relates to what's approved here and what's also going on in Europe. So that's why we have sort of a varied crowd. But Randy, maybe we could start out with a few topics that I've been interested in. One of them is how do we start a program? So our hospital, we've done 2 mitral clips, for example. I'm actually very interested in the technology and do think there are patients that we should be trying to treat, but maybe some of you guys could tell us about your experience getting started.
Well, you know, one of the things we had talked about, and I think pursuant to this, is their concept of, are they involved in a TAVR program, and you know, if they were, are they primary or secondary, and then maybe transition that into the mitral clip? You want to do that?
And then the learning curve. Like
Yeah.
How do we actually,
So
if I wanted to start a program and I want to pick one of my guys to do it, how do we do that?
So, Vino.
Sure. So we started our TAVR program in 2007, and we actually did mitral clips with Peter Block very early on, and then we stopped doing them for a while. And then Vasilis and I, as we built a successful TAVR program, started working together and reinitiated the mitral clip program. So similar to Gaurav at UVA, our TAVR and our mitral physicians team are exactly the same. And so it's been a very natural progression. We see valve patients, AVR and MVR patients in the same clinic on 2 different campuses on the same day. And so we're able to kind of take TAVR into the mitral valve. Our same TAVR research coordinators, we have 8 of them, they do all of our mitral trials. So we built kind of one valve platform, and we're doing, the same team is doing TAVR and mitral. So it was easy for us because we just, when we talked to our TAVR referring physician, said, hey, by the way, you know, we do mitrals percutaneously too. Do you have any patients for us? And that really has exploded us in 1 year, where we were able to do 40 or 50 mitral clips in 1 year. And that, I think that's what helped us get quickly ramped up.
Gaurav?
So we started a little bit inverse. We had mitral clip when Everest 2 started, even before we were a TAVR program. We were a TAVR program when the Partner 1 trial started. So weren't one of the initial sites, but we're fairly early on in that. We'd already had a mitral clip program. I think what's allowed us to be successful really is the collaboration between the team, and it's the cardiologist and the heart failure, the interventionalists being Scott Lim, who many of you know, being willing to train surgeons how to do it, and allowing us to be the primary operators, allowing us to do it independently. And I think when you do that, a lot of the referrals that we get for mitral clip actually come from surgeons, or come from surgeon to us, another surgeon. And some of them we treat with surgery, but many of them are high risk by appropriate means and are reasonable mitral clip candidates as well. So I think that collaboration's been a really important piece to allow us to grow.
Francisco, and I'll come back to you, Rob. Francisco, what's...
You know, I think in general, this is a program that is difficult to learn from everybody. Whether you come from cardiology or from cardiac surgery, it requires re-engineering yourself. And the best way to do it is a team, so that you play together. I think the best way is to just sit down, go to a restaurant, say, okay, in the next 10 years, we work together. And if you do this way, you're successful. You know, the definition of the heart team. You know, the heart team is a structure that it is designed to support this program. but the structure is composed by a real, a hypothetical structure and a real structure. The real structure is basically probably 50% of the heart team. 50% of physicians really believe in the heart team. And you see them in the morning at the cafeteria, they get coffee together. This is the heart team.
Interesting. So morning coffee and evening meals at a nice restaurant, though. You go for a nice restaurant. Is that the deal? So, Mike, I'm not trying to take this away, but I know you and Rob have been intimately involved in both the TAVR and the mitral space. Isn't that right? And Rob, I think you mentioned that you all have sort of, going back to David's questions, you all have sort of separated out roles. You're the mitral. Mm-hmm. Mike has been more of the aortic. Is that correct, Mike? Is the surgeon doing the interventions?
Well, not exactly. I mean, the way that we started our mitral program was about 2009, and actually Seibel came and proctored us and taught us how to do it. And Rob has taken over the program, and why don't you talk, Rob, about how you assimilated this, how you got up to speed, and now how we run the program.
Right, so my background was I had about 0.5% involvement in the TAVR program, which is basically I would just send patients who were not good candidates for surgery. So I was not involved in the transcatheter program at all, but had a surgical volume for mitrals that was pretty large, and that's how I got interested in it. Mike had already started the program with David Brown, who they were our TAVR team. And I started going down there to learn some, but I did not come from a wire skills background at all. As I got into the program and started taking over, we separated out our valve clinics, so we have a completely separate transcatheter aortic valve clinic, and then we have a mitral clinic where we see patients who are candidates for surgery and patients who are candidates potentially for transcatheter-based therapies, and we see almost all the patients in the mitral clinic, which is basically the back half of my surgical clinic. And it's myself, one of our echocardiographers, Paul Grayburn, and then our interventional cardiologist. And we evaluate every mitral patient for not only whether they're a transcatheter patient, but whether or not they really should be a good surgical candidate. And then we're also looking at TMVR potentials as well. So we've actually really separated off. The only continuity with the TAVR program is that we have our interventional cardiologist. She works on both sides, but our transmitral or transcatheter mitral program is actually really a surgeons-based clinic.
So how do you deal with other, this is something that came up recently is in our own group at Emory, how do you decide if you're going to have one person do all the transcatheter mitral stuff? That means that they're going to do all the surgical mitral stuff, but Mike, you've got more than Brinkman and Rob as your two attendings there. So what happens to the other members? They just do no mitral work at all, surgical or transcatheter? Because I think that's a problem for a lot of people in the community is, they're not going to have that pleasure of just saying this person is going to do all the mitral surgery. And like David does it here at Mount Sinai. Explain that a little bit, how you can differentiate that out amongst your group.
Well, I actually was at the University of Michigan last week and just said that we very much adopted the Michigan model of we have primarily aortic surgeons and we have primarily mitral surgeons, and the same with our cardiologists, and moving on to other specialties such as thoracic aortic and coronary revascularization, et cetera. So, our program is large enough that we have the luxury of being able to do that, and I realize everybody can't, but I think that has served us well. I must say that we did start our mitral clinic, our transcatheter mitral clinic, as an add-on to our aortic clinic, because there wasn't a clinical or a critical mass there of doing it. But it was very secondary, and it didn't have a life of its own. And only when we separated it out did it really begin to take off. So,
I think the skill sets are a lot different, though, between TAVR and mitral clip. While they might be some of the same people initially when it starts, and it may branch off or it may stay the same, the skill sets are quite a bit different, and it's no longer as much of a wire skills-based procedure as TAVR is, as much as it is now an echo guided procedure, and understanding echo and anatomy and understanding how the mitral valve works, I think, are the critical elements. And that's why MitraClip, as Francesco mentioned, this is not a skill set or a procedure that any cardiologist can really pick up right away. It takes some experience, it takes some knowledge and understanding of echo, and why I think in general surgeons, particularly mitral surgeons, are fairly well positioned to learn this if they wish.
So Rob, why don't you go through how, you said you had no background in wire skills. How did you get up to speed?
So I do a lot of minimally invasive mitral surgery, and so putting in a large femoral venous sheath is not very difficult. And so that's kind of the first introduction to the MitraClip, is just being comfortable putting a large femoral sheath in. The transeptal is really the crux of what you need to learn as a surgeon for doing the procedure. Everything else is completely novel to both the interventional cardiologist as well as to the surgeon. It's a device, and you have to learn how to use the device. But as a surgeon, you know a lot more about the structure and the function of the mitral valve and how to go about repairing that and what the effects of that repair may be if done inappropriately. And so you have a lot more to add to the actual placement of the clip and the planning of the procedure. But the transeptal is what I definitely had to learn, and that's where interventional cardiologists have been huge in teaching me interventional or in transeptal skills. And in particular with the MitraClip, getting transeptal is actually, that's the whole first half of the procedure, and even though it may go quickly, that can be in some instances the entire procedure. If you put a bad transeptal in there, you're going to be struggling with the whole case. So learning that skill takes time, and that's where our interventional colleagues have been huge in training us.
But that also goes to the many interventionalists before MitraClip didn't perform transeptal the way you need to for MitraClip.
Right.
It's very specific where you need to
The EP
be.
guy.
I guess I'm getting at the EPs, that anywhere in the fossa is fine for them because they can navigate. When it comes to the MitraClip, it's very specific, and again, it's echo that guides you. So if you have an outstanding echocardiographer, I think that's a huge help.
I would tell you that the first place to start, I think, is getting on a simulator and learning because the catheters that you use are varied. You could use 2 or 3 different catheters to do your transeptal. So I would say that the first thing to do is, if you're interested in it, get on a simulator and learn the different catheters that you can use. When do you use them? If the right atrium is too big, when do you use it? What the right atrium is a relatively normal size. So that's the first step, and then I think you get into the cath lab. And that's kind of what some of the ways that we did it.
And that's where working with your EPs can help you to learn those things.
Yeah, and I agree with that. So the way I initially learned how to do it was actually coming up here to a course in New York and on the simulators. But then I went back home and my newest best friend became an electrophysiologist. Right. And for every AFib ablation, they do 2 transeptal procedures. So I had to do 10 to be able to get credentialed to do them.
In your hospital?
In my hospital. So it took 5 AFib ablations, and they actually were nice enough to time them, so it didn't interfere with our surgery schedule. So while a patient was getting ready for surgery, I could go to the EP lab and do 2 transeptals, and it would take 15 minutes, and it took me 2 weeks to get credentialed doing it. And the electrophysiologists, not for the most part, not the interventional cardiologists, unless they're already doing MitraClip, are the ones to learn from.
Francisco?
I've been proctoring a MitraClip in the last few years to many interventional cardiologists, and I have to tell you, usually I had always to do transeptal for them. They don't know how to do it. It's really difficult to find an interventional cardiologist who knows how to do transeptal today. So I think that is obviously a very critical step of the procedure, but don't underestimate the importance of having the interventional cardiology background when you deal with this procedure. Even handling the wires is something you need to learn. You have a wire in the left atrium. If you don't clean it always, if you don't be careful to add embolism, there are so many little details that make this procedure potentially disaster if you don't have that experience. So I don't think a surgeon can go directly into MitraClip with the simulation. I think it is important, if you really believe in this future, take some time, spend 1 day a week, go to the cath lab, understand the environment, understand how to move the CR. There's a lot of things that you need to learn around the device. The device itself is very simple. It's a robotic arm at the end of the day. But that's...
If you have TAVR experience, that helps you. You get a little bit of a head start.
Absolutely, absolutely.
But I think, I mean, to that point, a lot of it is understanding the pathophysiology in a cath lab setting of mitral regurgitation, understanding how to interpret left atrial pressures, how to get a transmitral gradient in the cath lab. I think those things are skill sets that surgeons don't learn, but certainly can learn. And that's more than, it's a little different than just wire skills alone. It's really understanding pathophysiology in a cath lab setting.
Let me ask you guys a little bit more about the patient clinic. So Michael, now these patients come and you guys have set up a valve clinic. Is that changing the dynamic of referral, or what's going on with the sort of decision making like that?
So Rob, you want to take that?
Yeah, our referral has come actually three-pronged. So referrals mostly will probably come through the surgeon. For us, I will send patients directly to the mitral clinic. We get patients who come for Dr. Mack's clinic or my other partners who they say, this is not appropriate, and they send them to me to look at for MitraClip. We get the other half of the patients from our two cardiologists in the clinic who get patients directly referred to them for, because we have an active mitral valve clinic, they get directly sent to them because they have good relationships with them from TAVR. So we get them from both ends.
Okay.
So I guess we've, since we're involved from Everest 2, we've got relationships. Most of our patients actually come from outside UVA. And traditionally they've come from cardiologist to cardiologist, being Scott Lim had been involved in that right from the start. What we're seeing now is that there are many surgeons out in the community that are referring to us for MitraClip, whether it's to Scott or oftentimes to the surgeons as well. So I think that's hasn't really taken away from our, in fact, we have an abstract here looking at how does the MitraClip affect our surgical volume, and it doesn't seem to take away. In fact, it's added our volume by about 30%.
And let me ask you about those referrals for COAP versus intervention for high risk or extreme risk patients. Tell me about that. Or have you guys seen some renewed interest in that trial from the heart failure community, or what's your sort of current perspective on that?
Well, I would say for us, it's not really been the heart failure community that's sending patients in. We're not getting this big influx from our heart failure clinic. We're actually, the patients who are coming for coapt evaluation are the ones who are coming in through our cardiologist typically. And so it's a patient who's got troubling MR, moderate degree of LV dysfunction, and they're sending them on for a second opinion, a cardiologist second opinion, to see if there's any way for a percutaneous intervention. All the degeneratives, though, have mostly come in from the surgeon's aspect.
So I'm very dismayed that our heart failure program hasn't sent more patients for COAP. And the patients, I can't actually understand it. And the patients they do send us have an EF of 10 to 15%. And at that point, you're below the COAP, which is 20%. So, they're either sending it, they're not sending it, or they're sending us an EF of 5% mitral. And they're like, oh, can you do a MitraClip? Well, no, we can't do a MitraClip. So, David, I'm not sure for us how it hasn't worked, and I can't figure out why.
It's one of the things Reed brought that up, because we need to come up with some ideas to make that more obvious. It's safe. So it's not that you're putting the patient at this extraordinary risk for a procedure that's unproven. So it really is, imperative we enroll that trial.
So you ask yourself whether we need to have better education. Most of our talks that we give from MitraClip, maybe they haven't been in the heart failure meetings because maybe European data. When we show it in ACC or stuff, I'm not sure the right people are hearing the message that we should be sending these patients.
Well, I work with the current president of the European Association of Heart Failure. He is our cardiologist of the heart failure clinic. And we discuss this topic very often. The problem is that at the moment we are in a situation where 20,000 patients have been treated and very limited data has been collected. And so the heart failure community is totally data-driven. They don't believe in this therapy until they see the outcomes of the trial. But on the same time, they're not sending patients for the trial. So it's a little bit of competing factors here.
Mike, you're a co-PI. Catch us up on what's
So
happening.
you're absolutely right about this, David. First of all, I mean, this is a seminal trial in this field, and it's about half enrolled now. There's 207 patients out of 430 that have been enrolled in it, and everything else in the field is going to coattail off of that trial. There's a number of lessons from it. Number one, there are two of the co-PIs are heart failure specialists, Bill Abraham from Ohio State and Joanne Lindenfeld from Vanderbilt. And it is interesting the lessons that we learn from them. One is the treatment of mitral regurgitation does not cross the mind of a heart failure specialist. It just is not part of their treatment paradigm. If you look at the Duke database, only 11% of all patients with moderate or severe mitral regurgitation over a 20-year period of time were ever sent for surgery. And the worse the ejection fraction, the least frequently that they were sent for surgery. So it just doesn't cross their mind. The second is, if you look how a heart failure clinic runs, it's run mainly by mid-level providers. You know, the heart failure specialist is in a supervisory role.
Yeah.
So they actually don't see the patients the majority of the time, and there's no routine echoes done. I mean, the last echo may have been done 3, 4, or 5 years ago, and if it was done to evaluate what the ejection fraction was, and you know, they look at a report and not actually the echo to see if there's any MR there. The third lesson in the COAPT trial is guideline-directed medical therapy really does work, and Rob, you can attest to that.
Yes, I'd say over half the patients who've come in for co-opt evaluation, we've adjusted their medications and they've gone down to mild mitral regurgitation. That's been our experience, which is great for them. We've helped them and their cardiologists. We've been basically another heart failure clinic for most of those patients.
They'll come on one drug and that's it.
Yeah, but you can always tell where a patient comes from the referral. Mm-hmm. Supposedly they all come on a guideline-directed medical therapy, and the only ones that do are the few that come from the heart failure clinic.
Right.
Everybody else has a whiff of Coreg, if you're lucky, and when they really get on guideline-directed medical therapy and resynchronization therapy when appropriate, the MR does go away.
Interesting.
So David's original question was, how do you get a program started? Now, you guys have all been training teams that are starting up out at the Abbott facility, and now you're going to be doing it this summer in Dallas. Rob, I mean, you've trained a whole number of teams now. What are the common things that you guys have seen that are successful and not, and what would be the advice you guys would give on how to get a program going?
I'd say we actually got some feedback from our last training group, and we could tell the groups that were going to be good. And the guys who come in, the folks who come as a team, so it's always a strong echocardiographer, someone who's passionate about mitral disease, a surgeon who has a very reasonable surgical volume of mitral repair surgery, not just mitral surgery, but actual mitral repair surgery, and then an interventional cardiologist who's actually buddies with the surgeon. And you can tell that because they're interacting. It's kind of like what Francesco was saying. These are folks who are actually friends outside of just the hospital setting. And when those folks come in, you hear about what their times were for their first clip placement, and most of them are 45 minutes to an hour after going through the course and then picking a suitable first-time case. And so those have been very good feedback for what you hear some of the horror stories of some of the early MitraClip placements being 4 hours plus. That's not been the case for a lot of these folks who choose suitable patients.
Yeah, I mean, I agree with that. The team, where I get concerned, we've done some courses also, is that when you have the surgeon kind of at the window looking outside and the interventionalist is actually on the simulator playing with it. If that's the scenario you're at, it's going to be an unsuccessful program, or the surgeon's not going to be a part of it. If they're both on the simulator, working right next to each other, talking to each other, and say, hey, dude, you didn't do that, that's going to be successful. But if somebody's out there just kind of answering their text the whole time, not engaged, it's not going to work. And don't even do it. Don't waste your time if you're not going to be engaged in it. I think that's really a key thing.
So we've had a number of courses at University of Virginia where people have come. I've actually gone out and proctored a few sites on their first case. I think it comes down to a couple things. I agree with the things that Rob said emphatically. The echocardiographer is the key, but the other part of it is they need to have the right patients. And if they don't have a large mitral practice, what I'm seeing the places that struggle is they're hoping that this gets them a larger practice, okay? And David, I won't tell you where it is because it's probably closer to home than you want, but
I'm not gonna
places
worry.
that want to try to grow, and the patients that they're doing their first cases on are not optimal cases. Maybe they're a lot of mitral anticalcification, or they're a small valve, or they have a lot of tricuspid regurgitation, things that in the end may not portend to a great long-term prognosis. And having the right patient base to choose from, I think, is an absolute key, because you definitely want successes initially as you're starting a program. Otherwise, everybody's egos and enthusiasm is going to get deflated, and I think that's really important.
Let me ask you about the economics of the heart team. Like, how does that work? Because if you've got these two, it's the same thing with the TAVR, but I'm just curious on the mitral side how you sort of, what your experiences have been and what's going to happen with that.
So I know Vino's got some specifics. I can tell you, so for TAVR, we're able to co-bill. For MitraClip, we've been a little less successful if there's two physicians involved. So the approach we've taken is one person will bill, and it can rotate between the surgeon and cardiologist in terms of the physician side of it. The hospital side of it had been a challenge. I think that's gotten a little bit better with the add-on payment in October, so I think that's made it certainly not as much of a money-losing endeavor for the entire hospital.
So for us, Vasilis and I, who's my kind of, like David Brown for Mike Mack, is kind of my cohort as far as interventionist goes. We're neither one of us, we have a straight salary. We're not RVU based, we're not volume based for the most part. We just get a single salary and that's it. At that point, it becomes relatively easy for Vasilis and I, right?
I think I want to move to Atlanta. So then what?
And so so it works out well. For our younger guys, it's a little bit harder. So if you're RVU based, I wrote this down because my administrator sent it to me. Your work RVU for a mitral clip is 19.5. CABG is 33.7. A TAVR is 15.7. So a work RVU for a mitral clip is more than a work RVU. This is me personally, my part of it, not the global thing. A TAVR work RVU is 15.7. An open mitral valve replacement is 50.9. That goes to David. And then there's the AVR that's 41. Okay? So I'll just say that real quick. Work RVUs, mitral clip 20, CABG 34, TAVR 16, open mitral 51, and open AVR 41. So, it works for us because we want to grow the program. We believe in the technology. We believe it's the future. We believe that it will lead to the skills needed for mitral valve replacement, and it's our mindset. So that's why we do it. Is it an economic gain for me? Probably not, but then I don't have to worry about it at my level.
So Francesco, what about in Europe? What's the deal in Europe?
Well, dealing Europe is Europe is a large country. There are many countries. So if I speak about Zurich, no problem about money. Europe overall has been so difficult. Professor Alfieri probably remembers well. We started the mitral program paying from our own pocket, actually from the private pool. The first 10 patients were done like this, and then it was really difficult to go forward. I think, in principle, the economic of the heart team overall is a very important question. And the other question is, do we really need a heart team working as a heart team on each patient? This is the other question. Do we need 2 people to do MitraClip today? I mean, overall, it's always one guy is doing the procedure, the other one is learning. So what we do now in our practice, usually we are 2, but one is doing the procedure, the other one is learning. Maybe is a younger person. This is happening for TAVI for sure. Very, very seldom we are 2 expert operators on the table doing the procedure. I may go just to join because they're friends, but in terms of the economic and the real need for the heart team, as you grow, as you get this cross training, you don't need two people because I learned a lot of things. I can do a lot of things that the interventional cardiology would do and the opposite. So as we go forward, the heart team is a structure, but it's not needed in every single case.
I think Abbott said that whoever came to this conference gets to have 10 clips free. I think that's what I heard, to make the economics better.
Mike, you wanted to jump in.
So, the SGR got repealed last week, which is a great thing. But the flip side, the other part that happened with that is there's a lot of incentive now for alternative payment models.
Correct.
And everything's moving from volume-based to value-based. And it's already driving physician-hospital alignment, and it's going to drive it even more going forward. And one of my jobs right now is to figure out how to incent Rob to build the program, and he doesn't have to worry about how he's getting paid by generating RVUs in the operating room. And so there's a lot of different economic models out there that are evolving, and the lawyers for the first time now are letting us do something other than count RVUs. So for instance, for our cardiologists, we want them to go to outreach clinics and see patients. So how do you have somebody that could be doing procedures or stay in a clinic all day and generate RVUs, now tell them they have to drive 100 miles and see 3 patients? Well, they get compensated the same no matter whether they're driving or not, or a matter of fact, get compensated more by doing that. The same thing here. I want Rob not to worry about whether he's doing a mitral clip and getting 19 RVUs or doing an open mitral and getting 51 RVUs. He will be incented to build the whole mitral program as a whole. I don't think you can go totally away from RVUs. I think there has to be some basis in it, otherwise you get to a pure socialism and everybody plays golf and doesn't work. But I think figuring out, it said managing physicians is kind of like herding cats. You know how you herd cats? You keep moving the food bowl. And you got to get the compensation model right to incent the right behavior. And now that hospital physician alignment is getting a lot closer, that's going to be easier to do going forward.
Just to let you know, for our at Emory, we have a strong relationship with the healthcare where they pump in roughly, in order to sustain these programs, $250,000. And we've been doing that for the last couple of years. So when you are going to start your program, you're going to have an honest discussion with your CEOs to say, I want to build this. I need to support Rob, or for me, Eric and Brad and stuff, and say, I'm going to need this. We call it MOUs. We're going to need this for the next 2 to 3 years to make this program work. And I think that you have to have that relationship with your CEOs. Otherwise, it's going to be hard to do.
I think you're spot on. I mean, so one of the things we had gotten, we'd gotten a grant through the University of Virginia Medical Center to support our TAVR mitral clip program, and actually gave us $1 million spread out over a 4-year period. So
Same thing,
pretty similar.
$250,000, right.
And what that did, it didn't actually support any of our salaries whatsoever.
Right.
What it did is supported the clinic space, the mid-level providers, the research coordinators, and some marketing to some extent. I think that was a huge help and necessary if you're trying to start one of these programs.
Yeah, from our standpoint, it's a little bit different since we're a for-profit hospital center. So we actually have had long discussions with the with administration about this. And in fact, before the tech add-on payment came on last October, we actually had a moratorium on mitral clip placement because of the significant loss, and only really picked it back up. So our numbers are now starting to increase back again, and we had to rebuild those referral lines. Because we had it, then dropped it, and then picked it back up. So it was
for us.
Economics were a real deal. As far as the per physician side, the RVU basis has actually been pretty reasonable because you can finish a mitral clip in about 45 minutes to an hour, placing 2 clips once you become relatively facile with it. So you can do 2 of those in the morning and still do an afternoon case. So it's actually been fairly reasonable, and actually we co-bill the interventional cardiologist myself.
If you have a system set up, we do our mitral clips in our cath lab, and my ORs are downstairs. So we're doing a mitral clip, and the resident's taking a mammary downstairs. So by noon, by 11 o'clock, you can have 2 cases done. So there's ways to figure it out.
Yeah, I don't have anybody taking down a mammary. I just have to go do it myself. So I just stay later in the afternoon to do all this stuff. But
You're just a simple cardiac surgeon in a small private practice. Isn't that right, David?
We're
You
lucky.
wanna go-
We're lucky in
I
that
mean,
way.
I want to know how these guys are trained in the future.
I mean, I was going to ask you guys the same sort of question. That is, we know what's coming. I mean, it's like this behind the veil now. And Mike, maybe you can talk about that for a minute. I'm interested in your perspective. We know the transcatheter mitral valve replacement side. We just saw talk about apical neocord. We know there are transcatheter annular techniques. In other words, it's always hard to be the first one in, but sooner than later, transcatheter mitral intervention is going to become, I think, a regular part of our lives, and going to be a lot more discussions. I imagine within the next 2 or 3 conclaves, it's going to be half the meeting. And so that brings up one, how are we going, or most importantly, how are we going to prepare for that as surgeons? How do we train the next generation? We've got the pioneers up here with us, but is that going to become a routine training? Is that a fellowship? How do you envision that happening?
So I think it has to start with, I mean, the model of it is sitting next to me right here, is Francesco. So one is Ottavio supported him doing this as a surgeon, of going to the cath lab and spending a year with Antonio Colombo doing it, and he gained the skills, and his chief supported him all the way through. And you know, the same with Alfredo supporting the program at Cedars, and actually jumping in himself and learning the skills to do this. So I think you just got to jump in with both feet and do it. You know, sitting back now that things have transitioned to Rob, you know, our secret weapon on all this was our echocardiographer. I mean, just an absolute star. I mean, I remember when we started doing it, you know, we were there, he's saying, now turn the A knob. No, the A knob the other way. You know, he was, you know, truly directing things there. And I watch Rob now, and, you know, he is so skilled at it, because what he does is he sees it every day in the operating room. He's so conversant with knowing how to look at echo that it's easy for him to do it. So I would say the surgeon has an advantage here to do it. But like I said, you got to commit the time to do it. Like David said, this world is coming. It's coming immediately. In many ways, it's here. The replacement stuff is going to be a big deal. Right now, most of those can be done transapical, so a surgeon is a lead. And I say, don't let this slip through your hands.
You have to be, I'm sorry to jump in, do you have to be a super well-trained mitral valve surgeon first, or is the surgeon training 5 to 8 years from now going to be majoring is it a hybrid, or I mean, David, what do you think? I mean, that's what I'm trying to get at. I mean, because you're mentioning all of you guys came out of being well-trained mitral valve surgeons.
I think there's 2 potential pathways. One is people who are currently middle-aged or whatever age they're going to be in going into it. Next is the next generation. So, for instance, we have this is our 5th year now. We have a 1-year dedicated fellowship. They do transcatheter aortic valves, and they do transcatheter mitral valves. So they have to spend an entire year. That is their dedicated post-cardiac surgery residency fellowship. So we have a 1-year fellow for that. So I think we're going to need to do that, Mike, right? We're going to have some fellowship. David, I don't think you can do this just, you know, you're finished and you're going to just try this. You're right out of residency. I don't think you can be able to jump into this. So there needs to be some dedicated time. For those who are already out in practice, we have to find a second pathway. So I think there needs to be 2 concurrent pathways of how we're going to train the future.
I think there's 2 parts of the skill set. One is the wire skills, one is the echo skills. And I agree. I think the surgeon that's an experienced mitral surgeon has already learned those echo skills. They need to potentially learn some of the wire skills in cath lab. I think that the folks that are in training kind of have the opposite. They are getting the wire skills. They may have some exposure to echo, but they don't necessarily understand echo the way we need them to for MitraClip. I think all those can be taught in either approach, like you said, but I think those are the 2 skill sets that are important. And I think moving forward, as we talk about TMVR, I think this is just the portal to get there. And so now's the time to start learning those things. Learn how to do a transeptal, learn how to use echo to guide you, learn how to navigate the left atrium with echo, and those things will help with all these technologies, whether it's neocord replacement, MitraClip.
See, all 4 of us learned after we already had our practice, right? All 5 of us. We learned after
Francesco,
we
you
had our
want to jump
practice.
in? We do want to get a couple questions. I know, David, we all got to leave in a minute or so, so.
I think I have a comment here, which is, so I am now in a position, I am a director of a
Right.
clinic. And now I want to develop this program and to teach to my younger colleagues. I have a mixed team, some of them already fully trained, and they come to me, they want to do transcatheter mitral, they want to learn, so they try, they're coming, and also have younger ones. I have to say, it is very difficult at the moment to train somebody to go both transcatheter and surgery. If I get somebody who is in the 1st or 2nd year fellowship surgery, how do you train in both? It's very difficult, but we're trying to do that. Yeah. What is the good news? There is one good news. Surgery needs a lot of manual skills. It's a lot of doing. These procedures, you learn a lot by watching. Lot. 50–60% of learning is just doable, just watching procedures, asking questions, understanding the decision making behind. MitraClip, technically, maybe the first 20–30 cases may be a little bit confusing, but once you've done those, it's okay. The learning curve then is still there. You become an experienced operator after probably 50 or more cases, not because of the technical skills, also a little bit of those, but mostly because you need to take the right decisions. So watching cases, being there, being passionate, it's just like mitral valve repair. You know, you learn by seeing many. Obviously, there is more end skills there, but here is the good news. It's easy to learn.
Questions? Anybody? You raise a hand, you can go to the microphone. I'll bring the microphone to you. Any questions? No questions.
While they're working their way
Comments?
to the microphone, I'll
Go right
tee
ahead.
off of what Vino said. So we are starting a fellowship in this, and we'll see how it works. And we're actually starting a structural cardiology fellowship and surgery at the same time. And we view the surgery fellowship as both catheter skills for TAVR and for mitral, and also minimally invasive valve surgery, both aortic and mitral. So that's the way that's structured, and teamed up with a structural cardiologist. And so they'll be their own heart team, they'll do clinic together and all that. And so
It's very effective, I think, Mike. I mean, I think
Are you
you're
doing a cardiology
so we
one
have,
also?
This is our 5th year now. We have a structural heart cardiology fellow under Vasilis, a structural heart cardiac surgery fellow under me. And Monday we do clinic, Tuesday we do TAVI, Wednesday we do TAVI plus MitraClip, Thursday they do open minimally invasive valves, Friday is an academic day. This is our 5th year running, and it's been actually
And
really
do those
good.
two fellows pair up together?
They do on Wednesdays in the MitraClips, but on Tuesday the surgical resident's by himself with just me and a cardiology attending, so there's nobody competing with the transcatheter cases. So the surgical resident, the cardiac surgical resident, is doing cases skin to skin by the time they're 6–7 months out and into it. So it's worked exceedingly effective for us. So I think you're going to really like it.
How do you guys think that the I6 programs will change this up? You know, we had an I6 resident come out and join our group, and she was a rock star with TAVR from the minute she hit the ground running.
She's an exceptional person.
I
She was the
agree.
first I6 program person, and I can say stuff about her because I'm not as related as you guys are. She's the first I6 person ever to
It's Texas.
finish.
We're not related, though.
Yeah, I know.
It's different.
Everybody is in
That's
Texas.
it.
But I mean, she's really, I mean, she was the first one ever to finish in the country from Stanford, and she is the cream of the crop of what you were ever going to find. I think it'll be downhill from her.
You want to make some closing statements, David, or since we need to?
Well, I just want to thank everybody for coming. I mean, it was fascinating for me sitting over here on the older side. I guess the two of us, Mike is always trying to creep over there, but with all these young guys on the pioneering side. But yeah, it is true, Mike. I love what you said about this really coming. As you always say, the train's already left the station, and that we are really going to have to become more facile in our approaches to training new doctors and in our current programs to keep them really relevant in the sense of not just volume, but offering patients all the potential modalities of therapy. I think if you're going to be a heart valve center of the future, like Rick Nishimura said a little while ago, you're going to have a catheter-based valve program, and that's going to have to be inclusive of mitral surgery. So I know we have a lot of work to do in our own program, and I'm sure that's true for a lot of people.
All right.
Thanks very much, guys.
Thank you, everybody, and thank you for Abbott for sponsoring this. Thanks.